lower arm or the forearm dysfunctional. Supraspinatus, basically the same thing, just a little slightly different than the infraspinatus. And the same thing goes for the trigger points in the CI. This makes this whole shoulder area very tight and may set up the circumstances where the elbow becomes another focus for the chronic pain. Pectoralis major, the same thing. You may get a referral pattern down to the elbow in that area from some of the middle trigger points in the pectoralis major. And the pectoralis minor, I should remind you, not only gives you this referral pattern that passes by the lateral epicondyle, but the brachial plexus that passes right underneath this tendon is a common cause of pain in the elbow, as this is the ulnar distribution is usually the first area which is affected by this thoracic outlet problem, which we'll discuss at another time. Treatment of lateral epicondylitis, again, rest. If you found trigger points, inactivate them, and you may in fact resolve the problem just by inactivating the trigger points, particularly if you do this with a laser rather than by injection or any other painful type of treatment. The patient will notice that their epicondylar pain, if it's not an active inflammation, will in fact disappear. Heat, if we're dealing with trigger points in the muscles, and appropriate stretching for those muscles. Avoid dropping the wrist into ulnar deviation. If there is a true inflammation at the epicondyle, then you can put an ice cube into a baggie and put it on there for 10-minute intervals, but avoid putting it on the muscles. Muscles do not like ice. An inflammatory area can be treated briefly with an ice pack. And you want to increase the thickness of any pens or tennis rackets, golf clubs, etc. that you're gripping, so that you don't grip things so tightly. Certainly the treatment of lateral epicondylitis, you want to check another muscle that is the supinator muscle. If this is tight, look for a trigger point along the medial edge of the radius. This muscle can entrap a twig of the radial nerve that goes back and up to the lateral epicondyle and usually causes burning pain. So it's a little bit different type of pain than the true lateral epicondylitis, at least in its early stages, and the supinator may be the underlying cause, entrapping that twig. And this is the supinator muscle with its trigger point here, and it's not the reference zone you're worried about. It's the entrapment of the twig of the radial nerve, which will go up here to this area, innervate this area. Okay, I think we've finished with the didactic part of this webinar. Are there any specific questions that you think might be of interest to all of our participants? If so, type your message into the box under the chat and we can answer them. And we'll see if there are any questions now. If you have other questions, again, I'll show you the website which you can access and leave questions or comments there as well. These are pretty simple areas. Are there a few questions here now? Let's see if we can to bring up a question. The question is, how do you clinically differentiate the lateral epicondylitis from the myofascial trigger points being active in the muscles? Well, first of all, you look to see what signs or symptoms there are from the case of a true lateral epicondylitis, where you run your finger along the lateral epicondyle, and if you do it very slowly with just your index finger lightly touching that epicondyle, the patient will tell you if there is a severe tendinitis at any point along that. Based on that examination, you may then want to look for the muscle that attaches where you've palpated this inflammation, and palpate the muscle appropriately to see if you can find a trigger point there, since that may be what's causing the tightness in the tendon and therefore the symptom of tendinitis, but it may not be a chronic tendinitis. It may just be there because the muscle is tight, in which case that will disappear when you inactivate the trigger point. So you sort of have to spend some time not only examining the site of the patient's discomfort, but other places. And their patients may wonder why you're looking elsewhere when they complain of pain at their elbow. And you simply tell them that in many instances, the pain at the elbow is coming from places in the forearm or the upper arm. And you're looking to see if that's the case, in which case it will be very easy to inactivate these trigger points with a laser without anything which is uncomfortable to you or creates any risk. So it's basically, you have to spend the time to differentiate the two. It's not that difficult once you get used to doing it. That can happen very quickly. Any other questions? Okay, then, let's show you some references which you may want to write down. The most important book you can get is the Travell and Simons Myofascial Pain and Dysfunction, the Trigger Point Manual. Volume 1 came out in 1983, and there's a second edition of the first volume, which came out in 1999. That is the upper body. The lower body, which is volume 2, that came out in 1992 and has not been revised. And I doubt whether it will be at this point, since both Dr. Travell and Dr. Simons have passed on. Mr. Maravino wrote a review article on cold lasers in pain management, and I think that was in Practical Pain Management in 2004. I wrote an article, a guest editorial in Practical Pain Management in October of 2006, detailing how my practice was changing because of the low-level laser. And if you haven't gotten into it yet, that might be interesting to read, and you can see how I actually changed my whole approach to dealing with my fascial pain in particular. And since myofascial pain and the related fibromyalgia, which is related but not equivalent, it has really helped in those patients. the fibromyalgia patients. And then Martin wrote a brief article in Practical Pain Management in 2003 on accelerated healing with pain reduction on the treatment with the cold laser. One thing I would add to you is if you're dealing with an acute inflammation that has just begun, the cold laser is likely to cause a mild flare-up of the pain initially because it increases blood flow, and that may tend to aggravate some of the symptoms of inflammation, which already has increased blood flow as the body's response to try to deal with that. Once the inflammation is chronic, the laser works reasonably well to speed healing and clearly helps to reduce the pain. And finally, I wrote an article that was just recently published in early spring of last year in volume 22 of Fibromyalgia Aware, which is the magazine of the National Fibromyalgia Association, where they asked me to write a brief article on the use of the low-power laser in fibromyalgia. And I think that is a really good example of how you would use this in treating these kinds of patients, which can be complicated, but which are very gratifying when they begin to feel better. And here is the email where you can send comments or criticisms, good, bad, and different, about our webinars. It's mymla30.com, and you address it to me at that website, and the phone number is 888-789-0745. Thank you very much for your attention, and I hope we have the pleasure of your company at some of the other webinars which we have conducted on different aspects of the use of the MLA30 cold or low power laser.